I'd like to welcome you to our presentation today. I'd like to begin by thanking Dolores Green for her unwavering support and dedication, as well as her commitment to the health and well-being of our community and our physicians. So with that in mind, I'd like to get started on a topic that's near and dear to my heart. I can tell you that in the past, without a shadow of a doubt, this has been perhaps one of the most challenging aspects of healthcare. From a reasonable vantage point, as we look at the kinds of things that we can do that can make a difference, I think Millie's story that I'm going to share with you now really exemplifies the challenge. So you might want to read along with me. Millie's a 76-year-old widow who lives alone in a senior apartment building. She gets by on a limited pension, Social Security. Her children don't live in the vicinity, so for the most part, she fends for herself. Millie has CHF and COPD. She's really on a first-name basis with the ambulance crew as they transport her several times a year to the local ED. She's typically admitted 4 to 5 times a year, more so recently, and it's become apparent that she's steadily declining with age. Each admission typically exceeds the average DRG-based length of stay, as she routinely comes into the hospital in a rather weakened state. Her average admission is probably 10 days. She's discharged on a long list of meds with, unfortunately, even a longer list of side effects, many of which she recognizes immediately. The local visiting nurses agency performs their typical assessment. They know her as well. And her PCP in haste signs a boilerplated home health plan with just a glance. Home health aide visits 8 times over the next month. A PT sees her on 3 occasions and gives her exercise handouts, despite the fact that she really can't read them. A local DME provides CPAP instructions, although she never really could get the mask to fit properly. Meals on Wheels visits daily, and a friend checks her refrigerator at least weekly for spoiled items. She typically misses her PCP appointments, and she's been readmitted 3 times in the last year. Now, I can tell you that most of you have a number of Millies in your practice, and it becomes more and more frustrating as our Millies tend to age, and we don't seem to have very good solutions for how to extend care to these patients. But let's move beyond Millie right now, and we'll come back to her at the end. I thought this would be a good introduction to what I call Bittman's Law of Flawed Discharges. It was originally Murphy's, but I figured this was more appropriate. Bottom line, anything that can go wrong post-discharge will absolutely go wrong. What are the typical problems? I think we all know them. The discharge instructions are not understood. I've even had nurses tell me that they have difficulty understanding them. Prescriptions don't get filled, especially when the patient gets discharged late in the day and is feeling ill. It only makes sense. They're not going to be able to get to the pharmacy. Medications are taken improperly, despite medication reconciliations that happen during discharge. I can tell you from a great deal of experience, the only way to do this is to actually reconcile the medications at home, when you can actually look in the medicine cabinet and in the shoebox. DME shows up late. Healthy food isn't available. The patient's been in the hospital for a week. The food is spoiled. Weakness and deconditioning certainly increases falls risk, which is the leading cause of death and disability in the aging population. Caregivers are not present, or they don't show up on time. and anxiety and distress are often overwhelming. These are not uncommon. This happens every day in the United States. It's exacerbated on weekends. So let me share another story. This is Mr. Hernandez. He's an 86-year-old guy with a history of COPD and type 2 diabetes. He lives in a high-rise. He's being discharged Friday after a bout of pneumonia, for which he was in for 5 days. His actual discharge was planned early in the day, but he didn't seem to get out until 6:30. There was some problem with transportation. The hospital care transitions team performed what they call teach back, meaning that he repeated what they had told him. They sent him home with a discharge summary, new prescriptions, a request for a new oxygen mask from a local DME, and they ordered a home health evaluation. Problem is, Mr. Hernandez gets readmitted on Sunday morning. What went wrong? Well, he arrived home at 8 o'clock after feeling somewhat confused, anxious, and hungry. They hadn't fed the guy since lunch. What was in his refrigerator was not edible. He couldn't fill any new prescriptions immediately. His pharmacy didn't have night hours. The oxygen mask was ordered, but it wasn't coming until Monday. No caregivers were available on the weekend. They were going to start on Monday. The home health visit was scheduled for the following Tuesday morning, and he couldn't read the discharge instructions. Hernandez was actually readmitted, not because of the original complaints, but after slipping on an area rug in the kitchen, hitting his head, and losing consciousness. Now, I want you to keep this in mind because this is really an important factor that I'm going to revisit. Most readmissions that occur within 30 days do not necessarily occur for the reason that the patient was hospitalized. So let's move on. I'm not going to read this chart to you, but scenario 1 is what I basically just shared. But let's look at scenario 2 because it could have been better. In scenario 2, instead of 8 o'clock, he's discharged right after lunch. A home health assessment was ordered actually the day before he was discharged, and it was set up so that the care coordination nurse and the assessment was going to be performed that afternoon. He wasn't going to be in the home alone for more than a couple of hours. His refrigerator was checked. There was a shopping list, and there were orders to basically secure the food for a dinner meal. And the PCP's nurse actually touched base with the home health nurse and patient that afternoon on Friday when he got discharged. There was actually a telehealth transitional care management visit scheduled for Monday. When he left the hospital, he was actually given a discharge packet, 3-day supply of medications. We used to do this in Pittsburgh all the time with our at-risk patients. The prescriptions were also called into a local pharmacy that basically provided local delivery, and the delivery was set for Friday afternoon, so he was covered both ways. DME was actually contacted 2 days prior to discharge with a change order for oxygen, which was delivered on Friday at 2. Visiting nurses was also ordered way before the discharge and scheduled for Friday at 3 p.m. And weekend coverage was pre-arranged because there was no way they were going to send Mr. Hernandez home without coverage on the weekend. All of this basically coincided with arriving at home. The hospital care coordination team noted the literacy challenge and alerted the home health agency. And the health plan, and you might think this is a little out of the normal realm, they actually sent a home health safety technician to Mr. Hernandez's home on Friday afternoon, and they did a false risk engineering assessment where they basically removed all the area rugs and they installed handrails in the bathroom. And again, as I mentioned, falls are the leading cause of injury and death in older Americans. This is the way it should be, scenario 2. Unfortunately, scenario 1 is far more prevalent. So why am I sharing this with you? I want you to look at this because this is so important. In 2013, I had the opportunity to lead a conference for a hospital that was working on its strategic plan. And they had a really neat idea. Rather than just planning financially or in terms of building, what they really wanted to do is to develop some clinical strategies. And I found this article in 2013 in the New England Journal of Medicine. It was called Post-Hospital Syndrome, a Condition of Generalized Risk. And what they basically said is that approximately 1/5 of seniors get readmitted within 30 days. And that as a result of their admission and their illness, they basically have a heightened risk for a number of conditions which appear to have little in common with the original diagnosis. And here's some really good statistics. If you look at the chart on the right, you will see that in the lighter blue bars, these were readmissions for other causes, 63%, 70%, almost 64%, and 79% of the time for heart failure. Let's see if I can get this going. For heart failure, pneumonia, COPD, and gastrointestinal problems. The bottom line is that people get readmitted, approximately 2/3 of the time get readmitted for challenges unrelated to the original reason for hospitalization. And I want you to know that when I started looking at this for that hospital board, the concept of a post-hospital syndrome never really previously entered my mind. I figured that most people were coming back because their original condition was not treated properly. I learned that that was not the case. And one of the quotes from the article is attention to sleep, nutrition, activity strength, and the judicious symptom management can pay great dividends. So this is something we all have to keep in mind. So where does that take us? It takes us to the topic that we're really going to focus on today, which is transitional care management. And this was set up based upon those cases that I presented to you, and understanding that patients were at increased risk, especially the frail or elderly, when they were discharged. The contributing factors that really set this up are obvious: changes in overall condition, debility, post-illness, anxiety. We often don't consider that, but that is a big issue. Self-management uncertainty, that's a big one, especially with the elderly and the early development of dementia symptoms. Changes in medication, I can tell you more often than not that these tend to be challenging for both patients and families. Poor communications, incomplete transfer of information, and I know what you're thinking with TeachBack, but I can tell you right now that the nurse that asks the patient what that little pill is for in the moment, and the patient can respond, "It's for my diabetes," really doesn't have a clue 3 days later. When we add to it problems with diminished functional status, health literacy, lack of available supplies, food or medication, and certainly inadequate education for support persons, it becomes absolutely obvious that we have to do something as healthcare providers to sort of head this off at the pass. The bottom line is that CMS recognized this. They also recognized the real challenge that we have to patients and their loved ones, and they decided to try to put together a program that would incentivize providers for providing better care in this immediate post-acute phase. And that's really where TCM, or Transitional Care Management, comes in. We're talking about the 30 days after discharge. What this exemplifies, in my opinion, is team-based, patient-centered care. TCM is best carried out with your entire team. It really requires a workflow. And that patient-centered approach gives us an opportunity to pool our best resources and our practices and come up with a strategy that's comprehensive, that's coordinated, that's truly efficient and effective. We really have to look at the value of the care that's provided and, of course, the level of satisfaction for our patients. And we often don't think about this, our providers. Meaning that there's nothing more frustrating than having a patient discharged from the hospital and readmitted the next day or so. I can tell you, in reviewing data from our ACO, it's not uncommon for patients to be readmitted on day 2 or 3. So CMS recognized this need, and they basically came up with the concept of TCM. So how does it basically work? One, it's designed to include 2 touch points. The first is really simple. It's a contact, typically by phone, within 2 days of discharge. How you doing? How you feeling? Do you have everything you need? If that contact is thorough, we can head off a lot of problems right there. If that contact covers issues like food, medication, DME, support, and symptom management, asking the patient if they're having a myriad of these challenges, then we can really act right away. The second is a face-to-face follow-up visit, either 7 or 14 days, within 7 or 14 days of discharge. It's a higher service level if you do it sooner. The bottom line is that that second visit, that face-to-face visit, right now, and I'm not sure how long, but at present is really covered by telehealth. So this is an excellent opportunity to touch base with your patients without really seeing them, but making sure all the bases are covered. So what are the eligible discharge sites? Well, not surprisingly, inpatient or psychiatric acute care hospitals. It could be a long-term care hospital or even skilled nursing facility. Remember, that's a rather significant transition as well. Inpatient rehab, hospital observation or partial hospitalization, and even partial hospitalization in a community mental health clinic. When the discharge occurs, there's going to be a new set of responsibilities for that patient and family. Where can the patient be in order to receive the service? They can be home, that's obvious. They could be in a rest home, but they could also be in an assisted living facility. So sometimes there's a transition from a nursing home to assisted living, and it can be performed there. So let's look at workflows. I think workflows are really where this is all about. How do we standardize what we do? Well, these are the suggestions that I have for your practice on a team-based strategy. 1, review the discharge information and make certain you fully understand it. 2nd, regardless of what it says in the chart, perform your own medication reconciliation. Now, I know what you're thinking. How do you do that on the phone, or how do you do that by telehealth? But it's actually pretty easy. You just ask the patient or family to hold up the medications and show you how often they're taking them. That's a really good time to suggest a pill box as well, if you have a person that's capable of handling it, or a family member who's willing to do it. Next, determine compliance with the treatment plan. Is the patient following the suggested regimen that was set forth in the discharge instructions? Or are they back to their old ways? And I'll give you an example. I've seen more readmissions, potentially preventable readmissions, from CHF patients who have actually gained 10 or 12 pounds in the first 3 days of returning home. You may be asking yourself why, although I think most clinicians realize this, because they're basically going back to their high salt diet, they're retaining fluid, and by day 3, they're dyspneic, meaning they're having difficulty breathing, and they wind up having to come back into the hospital for diuretic therapy or other interventions. The bottom line is that it's not enough to say, do you understand the treatment, but really to go through some of this and make sure that the patients are actually following it. A rather large part of this whole thing is providing the education for the patient and the family and the caregivers. Now, you're saying to yourself, probably, I understand the patient and family, but how about the caregivers? I tend to believe that when you do this properly, you actually touch base with the home health agency or the visiting nurses, and you basically come up with a plan on how you're going to address not only the patient's challenges, but what if something goes wrong? What if the patient spikes a fever? What if the patient has a little bit of increased dyspnea? How often are you weighing the patient? I can basically give you a host of things that must be considered. The bottom line is that tying everything together was really the idea behind transitional care management. So you're actually getting paid for quote unquote 30 days of service, meaning you're not only talking to the patient or the loved ones, but you're also touching base with others. Now, again, I know what you're thinking. You're probably too busy to do that as a physician, but certainly you can work this in to your care coordination or your TCM strategies team. Finally, CMS asks the primary care provider's office to do what they can to help with scheduling. And I know that sounds obvious, but sometimes just saying to the patient, hey, do you have transportation? Are you going to have any difficulty getting back to your cardiologist's office? And the answer is, well, I'm not sure. And I'm going to talk later about how you can tap into some community resources to close that gap. If you look on the right, I built this chart to really sum it up. So we start with the patient being discharged from the Transition Care Management eligible setting, which I went over before. You get an MX alert, okay, as practice, and you basically make your call within 2 days. My recommendation is you call the same day. You review your checklist, which is based upon the strategies and workflow that I'm recommending. And if there are no immediate needs, all you have to do is basically schedule your 7 or 14-day visit. On the other hand, if you review that checklist and the patient is unstable, then my feeling is you don't wait 7 to 14 days. Remember, those are the outlying times. You address the challenges immediately. And sometimes addressing those challenges are rather simple, and at other times requires the patient to actually be seen in your office. My feeling is if you start out on the right foot with these patients, you're going to do much better than if you have a haphazard way of calling the patient saying, I hope you're okay. I heard you were discharged, and can you come in 2 weeks? That really is not adequate. Well, when you get the patient, what do? 1, discharge instructions review. Really important to go over that. The medication reconciliation, really key, even if you have to perform it by telehealth. This is another key area. You should be able to go to your EHR and take a look at any pending tests or treatments. There might be a biopsy or the result of some lab that was sent out that was not available at the time of discharge. This is the time to review it. And of course, the last one is probably one that will give you the most bang for the buck or for your time, and that's looking at the psychosocial determinants of health. I suggest that you really do provide teach back with the family and the patient, that you do everything you possibly can to reconcile those medications. And I would not hesitate to say that asking them to take the medications out of their medicine cabinets or to show you what's in that medicine shoebox is really a good move. I think you review all the pending tests and you discuss them with patient and family or other consulting physicians. And in terms of psychosocial determinants, it's pretty straightforward to develop a psychosocial questionnaire and determine opportunities. And when you go through that checklist, which might only take a minute, that'll immediately key you in to the type of resources that are needed. We're really very fortunate in our area because we have Connect IE that was started a number of years ago, and that's a phenomenal resource. I'll show that to you later. That enables you to find the resources that the patients need at little or no cost. Of course, your final responsibility here is coordinating and scheduling with other providers or agencies. Are they going to get to their pulmonologist? Do they have a way to get there? And of course, to schedule a follow-up. This one sheet over here, I really think has to become the mantra of how you basically provide TCM care. And it'll make a world of difference to your patients. Let's move on. So again, the three components: the interactive contact, the non-face-to-face services, that could be speaking to pharmacies or other providers, and of course the face-to-face visit, which I mentioned before, that can now be done via telehealth. Who are the providers? Well, your docs, your clinical nurse specialists, nurse practitioners, PAs, or certified nurse midwives. You have multiple codes that we're providing over here, and we'll actually have this presentation available for you. I want you to know that I actually went through these codes with a fine-tooth comb and looked at the reimbursement compared to a routine follow-up, and I can assure you that these are higher, so you're being paid more to provide this level of service. So it's more than just helping the patient, it's worth your time. On the bottom, there's something a little crazy over here. It says that for the 2-day required communication, counting begins on the day after discharge. So that actually gives you the 3rd day. For the 7 or 14-day visit, counting begins on the day of discharge. So this is just technicality over here. And when we say 7 to 14 days, we're really talking about business days. Finally, I want to emphasize again that a lot of this can be handled remotely, including communications with others. This can happen via phone or telehealth. This can also be carried out by simply having your office speak with other healthcare entities that are involved in the care of the patient. So, billing considerations. These codes can be used on newer established patients. They can be billed in rural health centers or FQHCs. And this is interesting. If 2 or more separate attempts are made to contact the patient in a timely manner, but are unsuccessful, and other TCM criteria are met, the service may be reported and billed. So your persistence is really important here. The service can only be billed by one billing practitioner in the post-discharge period. And you can't really bill this within the surgical bundle 10 to 90-day service requirement. Should the patient need an E&M visit, evaluation and management visit within that 30-day service period, it's separately billable, but it may not replace your 7 to 14-day follow-up. And I really think that your focus should be covering whatever really needs to be covered in that 7 to 14-day visit based upon a thorough evaluation of that patient, really thorough communications. As we move on, this is what I was mentioning before. This is Connect IE, phenomenal resource, thousands of resources in a host of different areas. The tool is really phenomenal for your practice. You can basically provide the patient's zip code and they show you the resources in different headings that are available. It's also available in Spanish, so it makes it easier. And I really believe training your ancillary staff in your offices to use this on a routine basis is part and parcel of a great way to operate. This makes all the difference when you can tap into the resources that are already available and not just believe that your patient's condition is a fait accompli, meaning that there's really nothing you can do. I also think that each one of us should be connected to Manifest MedX. This provides alerts, which are used by Inland Empire providers, including large systems, hospitals, ambulatory care centers, IPAs, and hospitalists. I can tell you that we use this Monday through Friday for all of our patients who are discharged in our ACO and also in our dual eligible program with IEHP. And I know that the chart on the side says that the eligibility for $8,000 in participation incentives ended on March 31st, but I kind of know it's been extended. So this is something that if you haven't done, you really need to do in your practice. This is a big one. And when you start looking at the most recent legislature that's come out of Washington and the Office of the National Coordinator, all of us are being required to share our information. So this works back and forth. This is bi-directional communication. Really important to get on board as soon as possible. Let's go back to Millie for a second, because I want to tell you what happened with Millie. And again, I wrote this in 2013. Hopefully not 1913. Sometimes I feel that way. But in 2013, when I was working on that presentation, I actually wrote this and I called it Millie Care. So let me tell you what happened to Millie. Millie, as you know, is a sedentary 77-year-old woman who lives alone in a senior apartment complex. She gets by on a limited pension, Social Security. Her kids aren't in the area. She lives on her own. You know that she has longstanding CHF and COPD, but what's surprising is she's actually doing better now. She hasn't been hospitalized in more than a year, and she's been to the local ED only once in the last 6 months for a minor burn. This is the key part here. Millie's improvement began last year after a prolonged hospital stay when she underwent a comprehensive TCM visit with her PCP's care coordination team, including a PA, nurse, and nutritionist. When you talk to Millie, she refers to that visit as a turning point. Millie's care coordination team sees her on a regular basis. They identify transportation and food resources as needs, as well as counseling services that were arranged through Connect IE, which have greatly improved her quality of life. Her long list of medications has been considerably reduced. She's not reporting side effects. She now attends Silver Sneakers, which is a program that's offered at the local Wire Fitness Center for older adults, and she absolutely loves it. It's actually more collegial than it is exercise, but it really gets her out and gets her connected to other people. She now uses CPAP with a properly fitting mask, and she wakes up in the morning feeling more relaxed and refreshed. And most importantly, she no longer misses her PCP follow-up appointments because she really enjoys working with the team. She finds those visits extraordinarily valuable for her. It's not just coming in, taking her blood pressure and saying, you look okay and we'll see you in 6 months. But they really look at her checklist. They look at that protocol that they established during the TCM visit, and they make sure she really has what she needs. Bottom line, Millie's quality of life has vastly improved. The point that I'd like to make over here is one of the most frustrating things about being a doc is the fact that you see so many patients where you have that spidey sense that they're not going to do well. You know they're going to be discharged from the hospital. You know they're coming back. If you go into any ER, you look at the ED physician and you ask him or her, who your frequent flyers are, and they're going to tell you who they are. And they really don't have a great strategy for how to keep these patients healthy and how to keep them out of the hospital system. This is a great start. This is an opportunity for you to develop a team-based care module that can be used for your patients who are in need, where you can really make a difference. And finally, I'm going to tell you, when you deploy such a strategy, the one thing that's really amazing is that you and your staff are really going to be surprised. You'd be surprised how well patients that you may have thought never had a chance of improving actually get better. This is basically the end of the presentation. These are a list of resources that we provide through RCMA. I want you to know, throughout the COVID national health emergency and even before that, we really developed the kind of information that can help you solve many of the problems that you're facing. We have people standing by that are also willing to connect with you. If you have any questions, please don't hesitate to go to RCMA Docs, look at the area that you're interested in, and there will be contact information for a person who will call you back and help your office through that challenge. With that, I want to thank everybody. I'm going to end by asking Dolores if there are any questions for me, and we'll conclude.
Okay, thank you, Dr. Bittman. Appreciate your time and your knowledge. A couple of questions, but to the audience, if you have additional questions, please put them in the chat box and we'll get to those. So the first question is, if multiple attempts are made to see a patient and we're unable to contact them, what code can we use for the effort made?
I would use the lower level code.
Okay. And the next question, and it's right on our screen, the answer: how can we sign up with Manifest MedX? And if you look at the screen, you will see the contact information for Manifest, which is you can do info@iehio.org, or you can go on the website www.iehio.org. And any of the folks there can help you, or you can call the RCMA office and we can connect you directly.
And let me add to that, Dolores. I think this is so important that every practice absolutely get connected at this time. I mean, one, it's the law, but two, it's the right thing to do. And my feeling is we can no longer practice in isolation. When you look at all the challenges we face as physicians, and you look at all the complications that can develop, you really need to know what's going on. And I can tell you, over the course of the last 3 years, Manifest MedX has improved phenomenally. Not only do you have better information, it's at your fingertips, you can get the alerts that you absolutely need, but you can also look at some of their analytics software, which can tell you which patients you really need to focus in on. So this is not an advertisement for them, but this is really just a suggestion for what you absolutely need to do to run your practice effectively today.
And the other best part about this is the Manifest MedX. There is no cost for ambulatory practices to participate and exchange information, as well as Dr. Bittman indicated, there are incentives from the state right now to link ambulatory practices with an HIE. And so you can get a little paycheck for doing it too. So I highly encourage you to do that, but that funds from the state will end in August, definitely. There won't be an extension after that. So I encourage you to do that. The next question. It seems like proactive partnerships with HHN, DME providers, and pharmacies are required to make this really work well. Are there resources to help rank and select better HHN and pharmacies for our patients?
Well, that's a good question. I think that is difficult. I can tell you that long-term care facilities and home health agencies are in the process of getting rated. I don't know that pharmacies are, but what I always felt was valuable is to align with pharmacies that do home deliveries. Pharmacies also recognize the importance of medication reconciliation. So today, many pharmacies are willing to prepare the medications in packets, or I guess they call them bubble wrap for patients. So you can literally pull out a string of medications for a day, and it tells you on each one of these bubble containers when that medication has to be taken. That's far better than reaching into 10 bottles for medication and getting everything mixed up. My suggestion is you have some of your staff call around to the local pharmacies and ask them what are the services that they provide. If you're dealing with elderly patients, these considerations are of utmost importance.
Okay, that is the last of the questions in the chat box. So again, Dr. Bittman, thank you very much for your time and sharing your wisdom with us and your knowledge. And for everybody on the phone, this presentation, the slides are available. You can send an email to info@rcmadocs.org. You'll see the extension there, and we would be happy to send you the slides. They'll also be posted on the RCMA website at the conclusion of this presentation. So again, thank you everyone. Thank you to everyone for joining us today, and we look forward to having you at our next webinar.
Thank you.